good evening, everyone, and thank you for joining us for Season 5, Episode 15 of Doc Talks with Dr. Forrest, Tennant, and Friends. We have a special show ahead of us tonight with lots of goodies, but first we have something amazing to share with you. I'm going to turn it over to our wonderful family member, Patricia Irving. She has something special to share. Here you are.
Oh, Jamie, thank you so much. And thank you for your help with this. Well, I'm here to announce that we have a very special raffle that's going to happen. And it's to raffle off our pain awareness ribbons. And thanks to the person that designs them, she is going to give us free shipping. And then we as a group are going to pay for 5 of these to be raffled off. If you are here with us tonight live, you are automatically enrolled and will be on the list to pull. If for some reason you don't want it, just give me a direct message on Facebook or get in contact with me and I will be happy not to put you on the list. But we hope you do want to share, because the purpose is that this is to support the doctor-patient relationship. When you wear this pen, you are saying that you support our doctors that are struggling so hard to do the right thing. Those doctors that are like Dr. Ibsen and Dr. Parker and Dr. Anand. Think of those doctors as the ones that you want to honor. And that's actually what the yellow on the ribbon is. It's for our doctors. The red is for the patients and the severe pain that they're suffering and that they can't get their legitimate pain medication that they need. The black is for those that we've lost, those that could not deal with that horrible pain and loss of hope. And this is why we all need to speak up. You don't have to be eloquent. You don't have to know all the facts. Just speak from your heart and just say to people, this is what this represents, and I'm hoping that we can have a conversation. So please, please, please join me in wearing the ribbon and being proud to wear the ribbon and telling our story. Last but not least, if you don't win the ribbon, the site where you can buy it is on Etsy. And we have posted that information on the Doc Talk site, and Jamie will also make sure that's available for those of you who are watching. So again, thank you so much to all of you who want to participate. Thank you, Jamie.
And thank you so much, Pat. It is such an honor. And this is so important that people get this conversation started. And so, word of mouth is the greatest form of advertising, is what I've always been told, that word of mouth is faster than anything. And so those conversations must be started. And like you said, we just can't be silent anymore. There is no shame in being in pain. That is not a crime, but it is unethical. And to me, it's criminal to not treat that pain. So with that being said, we have a full show ahead of us tonight, and we have a very special guest with us featuring Steve Arians, Pharmacist Steve, and we also have our panelists, and we have a full show ahead of us. So Dr. Tennant, it's all yours. Please take it away. Thank you so much.
Pain relief, and you get nerve regeneration. In other words, I hope the supply is stable and that people can go back to where we were 7 or 8 years ago, to where you can get this, and it should be a first-line trial for everybody with adhesive arachnoiditis. And those of you who've got RSD or small fiber neuropathy or traumatic brain injury, it's worth you trying. Side effects are almost nil. If you do take too much of it, you'll know it, because you're either going to usually develop some acne, because it does raise your testosterone and your estrogen. If you really take too much, females may notice some of their hair start falling out. If it does, you got to cut the dose way back. Anyway, I want everybody to know about the pregnancy hormones. These should be used in pain medicine. Why it's not better known, again, is one of those mysteries to me. That gives me a good inroads to my next subject. To start off this session tonight, and me inviting Pharmacist Steve, and I've also asked our panelists something, and I'll tell you why in a second. I have here in front of me something called the National Pain Strategy. It's 84 pages. And it was done in 2016, right at about 9 years ago. Now, this is the foundation for what the federal government is attempting to do for pain patients. Now, there were 80 prominent names who wrote this document. Almost all of them from prestigious universities. Many of them were names at that time. I know a lot of them who were on this panel. They have some pretty good definitions. And I don't know how many of you have read this. I highly recommend it for those of you who want to be advocates, who want to sponsor legislation, who want to try to move the needle for the betterment of pain patients. You really need to know what they said back then. What they said back then is not so much what they said, but what they didn't say. Okay? It's what they didn't say. And I happen to know that the people who did this, for a lot of them that I knew, were very honorable people, gave it a first shot. It's actually pretty well written. And it's 84 pages, so it's like any government document. It's a little flowery, and it might be a little biased. And anybody who writes a government document always throws in their pitch for a little more money. So you have some of those things. What I want to tell you about the National Pain Strategy is what they called for was a lot of research, particularly on multidisciplinary care. And that's really what they wanted. They also were concerned about how to differentiate pain from opioid use disorder. They've got a great definition of opioid use disorder. Okay, a good one. Well, one I could live with. They have a couple of definitions that I want to pass on to you. Their definition of chronic pain in the National Pain Strategy was a pain on most days that lasts over 6 months. Okay? Their definition of intractable pain was simply pain that doesn't respond to appropriate therapy. Okay? Now, I'm going to just give you a rundown of what they did not say. Now, the reason they didn't say it, because it probably never dawned on them, probably never envisioned they would need it, because here we are 9 years later. And so the reason why we're putting on this show and why we have this panel and why we have a guest tonight is it's time to, what's happened in the last 9 years. Most of you know the controversies. People can't get their supplies. You got mandatory tapering. You've got resistance in taking care of people. But now let me tell you what they did not do in the National Pain Strategy. Any symptom or disease is classically and typically, common sense wise, divided into mild, moderate, and severe. Now, I've asked our esteemed panel to give us their definitions of mild, moderate, and severe pain, because you can't just talk about chronic pain. I mean, if you're trying to talk about chronic pain, you're talking about my bad bunion, okay? You're talking about somebody who gets a migraine headache once a month. You're talking about somebody's arthritis who's been farming a little too long, okay? You're talking about all those ads I get every week in my mail to get this new supplement for neuropathy. Now, who are we talking about here? If you've got chronic pain, I can't find. Now, the other thing I have here, incidentally, I have all the CDC guideline reports. I've looked at that. I got the DEA regulations. Red Lawhorn has just published a condemnation of some dozen or so government writings. I can't find where anybody's defined mild, moderate, or severe pain. Okay? Now, first thing we've got to do, if we're going to help somebody, is figure out who we're going to help. Now, I don't think that the person with mild chronic pain is really what we want to be talking about. I don't think. Moderate, maybe not. Severe, we need to be talking about who is the severe chronic pain patient, because it's my assessment that's who this program and who we're trying to help the most. But let's define it. Who has severe chronic pain? Okay, who are doing it. Now, the second thing about the National Pain Strategy is very interesting. There's something about it that is, at the time, I think they believed they were really helping us out. They said severe chronic pain should be, they didn't say severe, they just said chronic pain should be called a disease. Okay, I can tell you at that time that caused eruptions, and that was one of the reasons why they did away with the fifth vital sign, because pain, in the view of medical practice, is a symptom. It is not a disease. But what's even more interesting, in the National Pain Strategy, they did not call for trying to either determine the causes of severe chronic pain or any research or effort to treat the cause of pain. Now think about that. They said pain's a disease, and they did not call in the National Pain Strategy for the development of treatments to treat the underlying causes. They did not define the differences or gradations of chronic pain. And so in some ways, what they said was, we just are going to treat pain in a multidisciplinary system that's had a good outcomes, and that's where we're at. Well, I think now it is 9 years later, I'm sure those people who wrote that report would go back in and do it quite different. I don't think we're going to see another National Pain Strategy. I don't think we're going to get much reception in Washington. This thing's been beat to death. Okay, been beat to death. And so I think Mark Gibson put it well, we're on our own. But, so what I've done is that I'm going to have the panel weigh in on this, but I also want to bring Pharmacist Steve into this. And I want to find out some things about him. Plus, let's find out where he stands on, where we stand on how do we define severe chronic pain? Who are we talking about? What are the causes of severe chronic pain? And where do we go from here? So anyway, Jamie, can you get Pharmacist Steve on here for us?
Sir.
If we can't get him, let me move right on. If you can find him, bring him on.
Okay.
Let's move on a little bit.
All right. We sure will. Thanks, Doc.
Now, what I've done with our panel members is I've asked each one of them to give us their definitions of chronic pain. And also, I'd like to hear what they think are the 3 or 4 major causes of severe chronic pain. We also want to hear, how do you differentiate mild, moderate, and severe? Anyway, Pat, I see you're there up here right now, all ready to go. Besides red ribbons, let's have your knowledge. Okay.
Thank you, Dr. Tennant. Well, it wasn't an easy assignment. I ended up doing a couple things. One was I used Perplexity AI, so the new AI computer search, and it came up with the 7 for, and this is for intractable pain. And I kind of like it because it lists it in order of frequency. So what it says in the order of frequency is, first is degenerative spinal disease, both post-surgical and non-operable cases. According to them, it's 50% of the intractable pain cases. The next one is fibromyalgia, contributing to 15% of the cases. That kind of surprised me. Migraines and vascular headaches, 8%. The next one is neuropathies, including CRPS. And then congenital skeletal disease, such as scoliosis and kyphosis, arthritis, and the 7th one is cancer-related pain. So what was good really quickly is that AI pulled this list, and then I got the exact same diagnoses out of healthline.com. So that was a nice confirmation.
Well, that really is. No, now let's get, now how do you differentiate mild, moderate, and severe spinal pain, for example? How do we, were you able to either find anything on AI or develop your own ideas?
No, the only thing I found, I very much like your definitions, by the way, Dr. Tennant. They are logical and they make sense. The National Institute of Health, the only one they really call out is that would match is severe chronic pain. They call, and pretty much matches your definition, they call it high impact chronic pain.
Yes, yes, yes,
Yeah.
yeah.
But they did not define mild or moderate
Um,
in any of
no.
those studies.
I'm glad you say you like my definitions because I've changed them. I don't like them anymore. God guest convinced me that I don't know what I'm talking about. So but your list, in all seriousness, let's get that list down because that jives pretty much. It talked about genetic defects. I'd also, what we've seen is scoliosis is a much bigger player than I once thought it was, but also Ehlers-Danlos syndrome, and I'm going to guess A1 threw that in that pot. You see.
Yes.
And severe fibromyalgia is much more common than people think and what have you. So, and head trauma. Well, that's a good list.
That is.
And so let's get that down because what I think we should all do, we'll get this down in writing so we know who we're talking about. But all right, let me go on to a minute. Donna, are you out there? Because Donna has been out there digging on all kinds of. Donna?
She sure is. I did want to let you know, though, Doc, Steve was able to come in and he's here and ready to roll, just to let you know. So
Let's bring in Pharmacist Steve. He's a famous.
oh, okay. Is that okay?
It's probably more infamous than
There you
famous.
go. Hi, Steve.
Probably more infamous than famous.
No, we didn't say it was good. You can be famous with a lot of different degrees. Steve, before we get started, you're kind of modest. Could we get a little before we get into some of your technical expertise? We'd like to know a little bit about Steve. Tell us first off, you're sitting in some facility. Where do you live, and where do you habitat?
I'm in a room we originally designed as a bedroom. It's down my office because we only had one child. This is sort of my man cave with electronics wall to wall. I graduated Butler University in 1970, and I've been assistant managers and managers of chain stores and regional directors of some chain stores, and had my own pharmacy for 20 years and got out into in the early 80s. As you remember, the DRGs, people started getting discharged quicker and sicker. So I expanded my pharmacy into home medical equipment. I was doing home IVs and interals and respiratory stuff in the 80s and 90s. We got into fitting mastectomies and prosthetics and orthotic products. And we pretty much anything that we could do legally, we did.
Where are you located at? So
we're in southern Indiana.
Southern Indiana, okay.
We're in what they call Metro Louisville, Kentucky, and we get to put up this last 2 weeks with all the derby activities. So we don't go across the bridge these weeks. Go over there, all that craziness. But my wife was an intractable.
Hold on, I used to hang out across the bridge there. I'm an old graduate of the old Louisville General Hospital.
Oh my God, that is forever.
And
that's when they had kerosene lamps, wasn't it?
Well, it was candles. Yeah, but no, go ahead. That's funny.
My wife is an intractable chronic pain patient. She's also she's getting ready for her 4th implanted pump because They put 6.5 years on the battery, and that's when they call it. So this is her third one in 6.5 years. You can do the math of how many years she's had a pump with a PTM, a patient therapy manager. And so I've had a lot of firsthand experience with observing a chronic pain patient. Um, I have some issues myself, minor to what she deals with, but my general definition of pain is pretty simple. Most practitioners don't like it. Um, Average pain of 5 or below is tolerable, and anything above that's torturous level. And that's what I tell them. I go, I'm okay today, or it's up today, and pick whatever number you want between 6 and 10 that makes you happy. But I consider it a torturous level.
Yeah.
Um, most of my pain is from activity induced. Some people call it breakthrough pain. I call it. I'm a chronic do-it-yourselfer. I'd rather do something myself than pay somebody else to do it. And that's where I get most of my troubles in my lower back. So, um, but I say I'm rather simplistic on it. Is any doctor that expects a patient to live most of the time with a pain intensity above 5 is torturing the patient.
Steve, let me just tell you how I first found out about you. I got a letter from a lady, and I think I can recall almost to the word what she said. She said, "Dear Dr. Tennant, I don't like some of the things you've been saying, and if you know what you're doing, you're going to contact this man's pharmacist, Steve, because he's the one that knows everything, and you can learn something from him." So anyway, that's how I found out about you. But in all honesty,
How long ago was that?
but you've become very popular. People write to you all the time. How did you get into the education? And people like your wit. They love your humor. They love the way you communicate with them. And it's like you're giving us some vignettes here, which are very homey, and I like them. You're getting across to people.
Well, our pharmacy was fairly successful. I saw some cuts in home medical equipment, which was my cash cow. And I sold out in 1996 and retired at the ripe old age of 49. Um, Barb and I spent a decade bouncing around the country in one or two different motorhomes. We bounced between, our daughter was in the Bay Area. We had a condo in Panama City Beach, plus our home here in Indiana. So we just kind of, there's one state we can't agree we were in, and that was New Hampshire, because I said, well, I didn't see a Ben and Jerry's, so we must not have been there, because ours in Vermont. Which one are Ben and Jerry's is in? I said, that state's not that big. I would probably saw at least one Ben and Jerry's outfit. I didn't, so we must not have been there. But the other floor 48 we've been in. And we put about 70, 80,000 miles in two different homes and motor homes in a decade. And did in our 50s what most people do in their 60s and 70s. So I first started out with the first um, Facebook page is um, Pharmacy Roulette. You bet your life. And it was based on telling how pharmacy and health practitioners were sometimes doing more harm than good. And it just kind of ventured out from there.
Uh, well, you've been a real blessing to a lot of people, and I'm so glad you're here tonight. I want to ask our panel members to weigh in, because we're trying to get some, as you know, some consensus definition of what we mean by severe, mild, moderate, chronic pain, so we can get everybody on one sheet of music. Do you have first off, think about your definition. Could I ask our panel members, you guys, can you come in and get ready to ask Steve, frankly, anything you want to ask him? But
That was mighty generous of you to let him do that.
but we'll screen them for you.
Mm,
Uh,
okay.
yeah. Anyway, give us your thoughts on how we define or categorize mild, moderate, and severe chronic pain.
I kind of put it in two categories. 5 intensity and under is tolerable. Above 5 is torturous. And I try to keep it simplistic. And some people like myself, um, my body does not like me working with my hands extended, which if you do much do-it-yourself stuff, that's what you end up doing. Uh, so it um, it depends. That there's like CRPS is known as suicide disease, and they use the 50 scales, and the name just dropped out of my mind. Um, but in some practitioners that won't understand, pharmacists, probably the majority of them, that having more than one source of pain is not totally additive in as far as intensity, but it is somewhat additive intensity. And just because you're taking an opiate doesn't mean that you're going to suppress whatever pain. I always want to smack somebody when they tell me they came out of the hospital after surgery and the pharmacist said, "You're already on opiates. Why should you need any more?" Because you're an idiot. Um, that's I just don't understand these people when pharmacists in particular, when they say that kind of stuff. But um, that there's humans are Homo sapiens are so different. I think it's hard to really narrow down um, when you to get even a soft break between mild, moderate, and severe. That there's a fuzzy line between those individual classifications, and not every patient feels the same amount of pain. I had a pharmacist friend of mine had MS and never took any pain medicine at all. I thought, how do you do that? I don't know.
Steve, this is David. I have a question about your pain intensity scale.
Okay.
So I've seen many different pain intensity scales over the years, and the current one I'm using at my pain doctor where I go, the first 0 to 5 are levels of pain that you're able to manage yourself, and of course your ability to manage decreases as you go up. And then number 6, if you check that box, that means it would be so bad that you would be seeking treatment at the hospital. So is that something you understand also, or
Well,
how does that work?
as I said, my pain scale is pretty simple. 5 and under is tolerable. You can work through it probably with aspirin or NSAIDs or whatever. Above 5 is torturous, which means you need some help. So,
Yes.
and whether the practitioner wants to say 6 and 7 is not torturous and 8 and 9 are, I don't know. I just know I just know what I know about me.
Sure.
Let me go back. Donna, you wanted you to come in and give us your thoughts on the definition, the differentiation between mild, moderate, and severe. And then if you've got something you want to ask Steve. Donna?
I'm here.
Okay.
I was just looking through some of the definitions on the internet
You,
and
you
thinking
know, you
about.
keep, who is this handsome guy you keep hanging around with? Anyway, good to see you.
And thinking back to as many times as I've had to go to the ER, because of pain flares and such, and as many doctors as I've been through, and the dreaded pain scale, the 1 through 10, that really doesn't give you a chance to describe what kind of pain you're in, because of the way they've got it. I can remember the way they had it set up, like 8 to 10, that you're screaming in pain and have to go to the ER. But that's not always the case. You can be in that much pain, but it doesn't mean that you necessarily have to be screaming in pain. Those of us that have lived in chronic pain for years, um, have basically, I think most of us have learned how to handle it to an extent where you're not literally screaming in pain as I think that's how they teach them in school, what to expect with patients in chronic pain. And if you're not doing this, this, and this that checks their little box, then they don't tend to believe that you're in that much pain. That's just been my experience. They also go by your blood pressure. If your blood pressure is high, that can also contribute from you being in pain. Whereas with me, my blood pressure drops whenever my pain gets really high. I do the opposite, which is odd. But anyways, that's another matter. But I think with the mild to all the way up to the severe, um, with the mild, I think it's pretty much if it interrupts, comes and goes, interrupts some of your activities or whatever, but you can still push through it. Mild, same thing for intermediate pain, but when you hit that severe chronic pain, I think that really limits you on your ability to function a lot of time with your family to do activities and stuff like that. But even I think one of the biggest things that doctors miss is how patients, and I've said it over and over again, is how patients metabolize their medications. I think that's a big miss on doctors there also.
Good. Say, Scott, I want you to come in here and respond to that. And also, you had some questions on a differentiation between severe and moderate. Scott, are you there?
I'm here, Dr. Tennant.
Yeah.
I've been thinking about this for days and really don't know where to go with it. The pain scales say less than 5 is mild, 6 to 7 is moderate, and greater than or equal to 8 is severe. I really like Dr. Steve's, Pharmacist Steve's version of it. I mean, why are we breaking it into thirds? There's tolerable, there's intolerable. I kind of go of, mild is where you can still push through and have your life. You can, it's not interrupting your social desires, your hobbies, whatever. Mild or moderate is where you're giving up social interactions, you're giving up hobbies. Severe is you're kind of somewhere between I'm not getting out of bed and will you please hand me my rifle? And because we just have, as far as the definitions that some people were reading about screaming and going to the ER, chronic pain patients have realized the ERs aren't going to do them anything except turn them away and treat them like drug addicts, so they don't go. And people who've been, patients who've been suffering with chronic pain, they tolerate it as best they can. They don't get to the screaming, crying episodes, at least not in public anyways. They might in private, but it's just, okay, we're having a bad day today.
Yeah. Very good. Let's see, we haven't heard from Dr. Ribson, and he's always got, if not the final word, nearby. Mark, where are you?
Hi.
Good. Okay. You wrap it up here. What are we doing?
I'm with Steve.
Are you living in your car again?
Yes. So I don't need to define chronic pain. The patient does it for me. And I don't need to just define severity. The patient does it for me. And none of the patients walking in my door when I had a door to walk in or calling my phone are having pains less than 5. I think there's another category of pain patient, and that's the complex one and the difficult, challenging patient who has more pain than they can bear, and we're looking for a way to treat it. And that's becoming, of course, more and more difficult all the time. It sort of has always seemed to me and as I've developed more and more expertise in treating pain, um, that if the pain is disrupting someone's life and they can't do their activities of daily living, they can't make the bed, they can't make a meal, they can't do anything, or certainly they can't work. Those are people who are profoundly affected by chronic pain. My goal has been to measure function, and improve function enough so that people can participate in their lives. It seems to me like, why prolong life if it sucks? And most of my patients are suicidal at this point, the severity of the patients I'm seeing. So it's a suicide treatment program, prevention program now. It's gotten so severe. I think it's moving. It's a moving target, and it's sort of like the Potter Stewart definition of pornography. You can't really define it, but you know it when you see it. I know when someone's in chronic pain, and I can feel it, and I can even feel it through the phone. So part of that's my own empathy working, but you really, I don't think it's worth the time to decide: are you moderate, are you severe, are you acute, are you chronic, is it severe complex pain? I think all of my patients with trigeminal neuralgia and complex regional pain syndrome and adhesive arachnoiditis, we could just wrestle all day long about whose is worse. It doesn't really matter. It's like yours is worse because you're the one that has it. So that's it.
Okay. All right. I think what I'm hearing here is all of you seem to be talking about, and I didn't make it clear, because I just wanted to get this discussion started, because I have some grave concerns that I want to bring to you as I close out the program. But does anybody else here, Steve, Donna, Pat, anybody else want to say anything about the differentiation between mild, moderate, and severe pain, chronic pain, and the causes?
I think they have stopped looking at the causes. I think they look more to treat the symptoms than the causes. I had one doctor tell me that I had too much wrong with me, that there wasn't anything he could do for me, and put me right out the door. But more doctors look to treat what your symptoms are versus finding out what's causing the symptoms.
Yeah, okay. Now, let me ask all of you a question. What I'm hearing, I think, from all of you is you don't think there's any reason for a doctor seeing a patient to differentiate between the three. And you don't care what the cause is. That's what I'm hearing everybody say.
I'd like,
I don't see it quite that way, Dr. Tennant. I think the cause is very important, and the loss of function is very important. Let me just give a quick example and it doesn't have to be severe to impact your life. I have interstitial cystitis, and I would say it's moderate pain. It's not severe pain, but I can't sit in the car for more than 20 minutes, so I can't go social. I can't go out for lunch with somebody. I'm, really restricted in that way. And so for me, call it moderate, call it severe. I think the diagnosis does matter. I mean, how you definitely want to be able to, in areas where there's a pathological situation, like with interstitial cystitis, you obviously want to treat that originating cause. If someone has arachnoiditis, you want to treat that. On top of that, as a separate layer, is how are you going to deal with the pain that is ensuing from that pathology? So I would not throw out the diagnosis.
I'm going to agree with Donna on that one. You can't throw out the diagnosis because one, we're humans. We want to know what's wrong with us. The great question of why. It's somewhat satisfying for us as people to know why we feel this way. And then from there, I think that's kind of how we got in trouble anyways, because we just treated the symptom, which was pain, without really looking at the underlying cause and treating what the cause was. And we missed a lot of opportunity to decrease inflammation or treat neuropathic pain versus, which doesn't really respond to opioids. But if that's the only tool you've got, then, everything's a nail. But I think knowing what caused it, because a lot of times you can say, well, sorry, this is a genetic disorder and we can't cure it. And Donna's list that she generated, I noticed that the genetic disorders were missing. There was no MS, there was no Ehlers-Danlos, there was no sickle cell. So,
Okay, let me phrase the question again. Let's say you're a pain practitioner. Okay, and we've got a lot of big pain clinics now around the country, run by a variety of specialists. Does that pain clinic have an obligation, yes or no, to determine the cause of that pain before they prescribe a controlled drug?
No.
No. Okay. Scott?
if you've gotten as far as a tertiary pain clinic, the diagnosis or the cause should have already been determined in the referral. If it hasn't been, then they should dig a little bit, but I think the first thing they have to do is relieve suffering. That's what we do as clinicians.
What? Say that again?
I think what the first and foremost, we have to reduce suffering, and that because that's what we do as clinicians.
Uh-huh.
So
okay.
You're supposed to be healers.
In other words, yeah. Steve, what do you think? I mean, a pain clinic.
I said, almost all disease states, there's a spectrum of intensity.
Mild, moderate, and severe.
Well, no, I'm talking about, I was PIC of the second largest outpatient mental health facility in the country. And there's people with mental health issues that's over a spectrum, that they have certain amount of intensity on one side of the spectrum or another. And sometimes they're a mixture of some of the mental health issues. And some people are more tolerant of pain than others. And yes, if the patient has had something diagnosed, you should try to minimize the impact on the rest of their systems against that disease.
Steve, if a pharmacist receives a prescription for opioids and benzodiazepines or the usual treatments, should the pharmacist know or ask as to what the cause of that pain is?
Well, that's very, very interesting, because when I was practicing in the last 5 or 6 years, I temped. I just worked around. There was a huge shortage of pharmacists, and some weeks I'd work 60, 70 hours as a temp. But I would, where some pharmacists would try a 20 question inquisition, I would have a conversation with them. And in that conversation, I would get things answered that they didn't feel like I was nailing them for an answer. I remember one guy, he was he was on 80 milligrams OxyContin, and the doctor had prescribed it twice a day. And I went out to talk to him, and as I approached him, he started recoiling.
Okay. All right. Very good. These are very good. I want to carry it on next week. I'm going to leave you all with some questions. Okay. If you are an insurance company, if you are an employer of physicians, and 75% of doctors now in the country are either employees or contractors, should you as an insurance company pay for anything if there is no underlying diagnostic cause or determination whether that's mild, moderate, or severe pain, and why? Okay. Should a employer of doctors who's paying malpractice and knows about the overdose statistics, does that employer have the right to tell that doctor to forcibly taper somebody if they do not categorize the pain or have an underlying diagnosis, and why? I think you need to, I would suggest these are the questions I'd like to have everybody respond to next time, because these are the questions I hear all the time. Okay? And they're very serious. And unless those questions can be answered, I think you need to be prepared for three groups of people to take on the pain patient and the doctors. And that is the insurance company. How can they pay for expensive fentanyl patches or an intrathecal pump even, or OxyContin or even Valium, if they don't have a diagnosis of a serious condition and serious pain that's been well worked up and diagnosed? How can they justify that? I'll ask you that question. And so you've got the insurance company that may want to know the answer to that. You may have the employer of doctors. Now, remember, all the doctors are employed. All those forced tapers out there, I hear every day that the doctor doesn't want to do it, but his employer, his malpractice company, is telling him to do this because there's no diagnosis, there's no cause, we don't know whether that's a bad bunion or whether that's arachnoiditis. And lastly, the media. The media is very against pain patients and against doctors who treat them. And unless you're talking about, if you're talking about little mild arthritis or, itchy psoriasis once in a while, and compared to post-traumatic head injuries, then the media just assumes that this is a drug addict taking all this OxyContin. So what I'm getting at is that I'm going to ask the panel here that these are issues that have been brought to me. And since we started this show, I've been a little amazed at how many of these parties are asking me these questions. And these questions haven't been addressed in all of this federal documents. Okay? So anyway, with that, I appreciate your being here. I would like to close with one other thing. Allison Guyton, who's one of our great supporters, flashed on here that if you've got severe chronic pain, you better be able to document it with some kind of blood test and cardiac abnormalities and some objective findings. I think you might want to listen to Allison, because I think that we do have a crisis in the country, and I'm going to just submit this. If you don't know whether the pain is mild, moderate, or severe, and you don't have a cause for that documented objectively in the patient's chart, I don't know whether the insurance companies, whether the media, or whether the employer of doctors is going to pay much attention. Now, that's my personal view, okay? I welcome you, and obviously a lot of you disagree with that, and that's fine. I just think that maybe this debate needs to be out there, okay? And what I've heard here tonight, most of you are saying is, patients got 5 to 10, I'll give them what they want. We don't need a diagnosis, move on. And that's what I hear. Now, I don't know if that's what you meant, but that's what I heard, okay? So with that, we'll carry this on next week. These are serious issues, and I hope that we come to some kind of consensus. Good night.
Good night.
Good night.
Good night, and thank you all so much. Pharmacist Steve, I'm not the only one that's looking forward to hearing the rest of the story that you were telling. I'm sure you could see in the panel here. So lots of people are looking forward to hearing the rest of
If
that
they're still on
discussion.
there, I'll be glad to tell it.
Yes,
That would be
please.
great.
Right.
So it'll be within the
This-
same segment. But someone wanted to know, what happened when the man walked away, and
Now, he
everyone.
didn't walk away. He was sitting, and he
Mhm.
kind of recoiled in his chair because he was expecting me to go, "Oh, you're taking too damn much OxyContin."
Awesome.
And what I asked him about, I said, "Are you getting highs and lows of pain management?"
Sure.
And he said, "Yes." I said, "I would suggest," and what I suspected, and this was years ago before pharmacogenomics testing was even much recognized. I said, I would suggest you take one tablet every 6 hours around the clock rather than two every 12,
Right.
because you're getting a roller coaster effect on your pain management. And he goes, well, I can't take it. I said, look, you're still taking the same amount of Oxycontin every day. I just think you would get a more level pain management
I agree.
than what you're doing with what the doctor has told you to do. People don't understand unless they've been in your shoes.
That's right. A lot of people don't get it until they get it. And creating those dips and spikes oftentimes ends in having to chase the pain, which we all know doesn't work. So
Anything, allergies, pain, whatever, you try to stay ahead of it.
that's it. That's right.
Yeah.
Thank you so much for explaining that. And I hope that what happened after that, was it
Well, I mean, I was temping there, so I never saw the patient again.
didn't see him
So
again? Okay.
yeah,
I didn't know if there was.
I worked in independent stores. I worked in Kmart's and Myers and Targets, and I would see patients one time, and I would just talk to them. How's
Yes.
this working for you?
That's so
No,
perfect. Thank you for being the voice of reason and for not treating people like Dr. Ibsen was asking. He was interested in the way that people are treated. The true medical PTSD and the gaslighting is a massive problem. And so I'm glad that you brought that up. And I'm so thankful that you take people seriously. You believe people. And thank you for doing that.
I
We
may be the only pharmacist on the web that understands.
Yes, you very well may be. And you and Dr. Guess are both in the same boat, and you both are right here with us. So I'm so glad you and Pharmacist Guest are with us. So thank you both, and thanks to all of you. We will see you again next week. We are out of time, and thank you very, very much. You're not alone. Good night, everyone. Thank you.
Good
Good
night.
night, Jamie.
Good night.
Thank
Good
you.
night.
Good night.
I'm
Thank
going to
you
stay
all.
on,
Good night.
Jamie.
Thank
Love
you.
y'all.
God bless
What
you,
about
Jamie.
God bless you
the
too.
drawing? What
My
about the
prayers
drawing
are
for
with
the
you.
weekend?
Yes,
Love you
ma'am.
guys.
We
Love you
love you
What
guys.
too.
happened with the raffle for the
Yes, it
weekend?
is. You will automatically, every person that's here, all 30, I think there were 38, but we will have a list of each person. And so everyone that was here will be entered into the raffle. And so then you'll be notified if you were a winner. And Miss Pat is going to be taking care of that part. So
Thank you.
thank you all so very much. Signing off. Good night, everyone.
Good
Good
night.
night.
You're not
To
alone.
everybody.
Thank you all.
Love you guys. Stay
We love you.
alive.
Please stay alive. Yes.
Love you.
We love you too.